Today we're going to be talking a little bit, only about 7 to 10 minutes, about single ventricle heart disease and some exogenous factors that may impact outcomes in my patient population. We'll specifically be talking about airborne pollution. So a little bit about me. I started my career at Duke University. I did my MD there and started doing research in heart disease and metabolomics and genomics while I was there, and really got an understanding for how physiology and pathology and molecular medicine all sort of unite. And then I went to New York City and did my residency in pediatrics at Mount Sinai on the Upper East Side, and decided that pediatric cardiology and congenital heart disease was something that really interested me, and that took me to Cincinnati, where I did my fellowship, and now I am here for my first full-time position. So I'm really excited to be here and continue on. And just a little bit of background into congenital heart disease. So it impacts about 1 in 100 live births. So that's about 40,000 people a year that are born with some form of congenital heart disease. So that's well, not by far, but it is the number one congenital malformation that impacts children across the country and across the world. So it's something that is prevalent and important to think about, and has a large impact on health of pediatric population. So it ranges from the simple, so small defects, things that do not require surgery, that can be monitored or that sort of heal themselves over the course of time, to complex congenital heart disease, including single ventricle heart disease that we'll talk about, that require multiple surgeries within the first few years of life. So a wide range. And with advances in care, a lot of these children are now surviving into adulthood and the spawning of this new discipline known as adult congenital heart disease, or ACHD, and that population continues to grow. So the initial phase of life and survivability has now transitioned into quality and long-term health for a lot of people. So that's where my research sort of fits in. So I want to talk a little bit about my patient population and that single ventricle heart disease culminating in the Fontan procedure. So this is the normal heart. Blue blood comes back from the body on the right side of the heart, comes into the right ventricle, up through the pulmonary arteries into the lungs, gathers oxygen, becomes red blood, comes back to the left side of the heart, and leaves the heart and goes to the body, to the brain. Big circle. Now, the Fontan in single ventricle heart disease completely maps out these pathways and leaves the heart just pumping oxygenated blood to the body, with all blood coming back from the brain, from the body, bypassing the heart, and through passive diffusion coming into the lung pulmonary arteries directly, and picking up oxygen there. So it becomes a single use function, or a single function pump, the heart and the rest of the blood is just passively diffusing. And this can have lots of long-term implications as far as impact on downstream organs. And the things that can happen most notably in our patients are ventricular dysfunction. The heart gets weak over time, abnormal heart rhythms, arrhythmias, valve dysfunction, and endothelial dysfunction. And the organs that are attached to the heart directly, the liver, the kidneys, the GI tract, all build up pressure. And with that buildup of pressure, things like Fontan-associated liver disease, cirrhosis, spastic bronchitis from the lungs, and development of fistula, cardiorenal syndrome, and protein-losing enteropathy are all side effects of that increased pressure from that passive diffusion into the lungs. And anything that we can do to decrease those long-term sequelae of the Fontan is what we try to do when people are growing into that adult population. So the question is, how do some of we know about the intrinsic factors that impact people with Fontan physiology and their long-term outcomes and needs for transplants or long-term hospitalizations. Abnormal heart rhythms, heart dysfunction, those things are well known and documented, and we try our best to see how and mitigate those factors. But we know very little about how the exogenous things in life of those individuals really impact their long-term outcomes. We seem to see that exercise makes a big difference in long-term outcomes for these patients, but really we haven't studied those things in particular. But for regular adults who have otherwise normal hearts, we've done a lot of good research has been done, mostly by folks at the EPA in the past decade, looking at how we can take mapping of airborne pollution, proximity to major roadways, and other sort of environmental factors that may impact long-term outcome in people with normal hearts. And so this is a paper from 2018 out of the group down in Chapel Hill, the EPA in North Carolina, that looks at cardiovascular disease and exogenous factor-specific pollution. And you can see the major roadways through Durham and Wake County here in sort of orange and red, and then you can see sort of the highlighted factors or individual sort of points of data collection, and sort of these all correlate with an increasing trend overall in odds of hypertension and peripheral artery disease. So a nice correlation between sort of people who live very close, even though there are sort of wide bars, close to major roadways, and those that live further out in sort of more rural counties. So there's some good data to suggest that there are correlations between sort of this exogenous airborne pollution exposure and peripheral artery disease and hypertension. Similarly, a study out of Canada that sort of showed similar exposures to small particulate matter sort of correlated with congenital or with heart failure and acute MI. So these things do have a nice correlation with increased hazard ratios. They're, so small increases, 1.2, 1.15, but with a large enough population, you can see those impacts over time within the population. So do we see changes in these these CV biomarkers based on pollution? And I would say, yes, there are sort of good data now sort of coming out that say, with these exposures, we have information about outcomes, but we can also start to track sort of what exactly is going on in the body that might be causing some of these things. I wanted to point out sort of the WHO does have sort of guidelines on how much exposure might be hazardous, and they've sort of set this cutoff line of less than 5 micrograms per meter squared per day over the course of a year, with a goal less than 10 over the course of the year and less than 25 per day. That seems to be sort of one of the things that really makes the difference for sort of long-term exposures and mitigating cardiovascular risk in the general population. So this is a paper that came out fairly recently that looked at sort of some of these biomarkers that might be affected by exposure, and this came out of a group in China, sort of looking at their overall population, a large patient population, sort of what pathways within the body might be impacted by these circulating airborne particulate matters. And there's some interesting things that they sort of pointed out. GDF-15 is a biomarker that's been sort of implicated in cardiovascular disease in the regular adult population, macrophage metalloelastase, sort of an inflammatory particle, and then interleukin-6, the interleukins also being inflammatory particles. There seems to be some correlation between what we're seeing at the molecular level with some of our outcomes. And then the question is, can we correlate some of those to other things that we might be seeing in our patient population? And sort of to go back to that GDF-15, it's been linked to sort of multiple systems, including sort of chronic lung disease, over the course of time. But more importantly to my story is that GDF15 has been associated with increased hospitalization and mortality in patients with Fontan circulation. So there is something sort of associated, and we can start to draw lines between what we've seen in the general population and what we've seen in our single ventricle population, and start to sort of understand for the general population, we know that this is a risk factor, but could this be an even more acute risk for people who have single ventricle disease, have less cardiovascular reserve, and are more prone to sort of the impact of things in their environment potentially? So to that end, I started looking at some of the EPA data while I was in Cincinnati. So on your right is, these are all EPA monitors of airborne quality that they sort of measure on a daily basis throughout the Cincinnati area. So this is the Ohio River that runs through downtown Cincinnati, and sort of this is downtown Cincinnati, and you can see that there are moderate sort of airborne exposures within the downtown area and sort of along this highway corridor that runs up and out of Cincinnati towards Dayton, Ohio, but out in sort of parts of Kentucky, Ohio, and then Kentucky below the river, we see sort of a lower exposure. So you can start to pick out these differences based on individuals. And on this bar graph, you can sort of see the daily exposure rates for the Cincinnati area with peaks and valleys. So we can start to understand those exposures across time and how that may impact long-term health. So to that end, we started gathering all of the clinical data for our patient populations, our Fontan patients at Cincinnati, and started correlating that information, their morbidity and mortality data, with their address, and then mapping that exposure to find particulate matter against their some of their clinical data and see if there's anything to that. And then in addition, the long-term aspiration is to look at some of the more fine pieces of information we have, MRI data, cardiac catheterization data, exercise data, and some of our targeted markers, and really start to build out the story that I think is true. We've started sort of a little bit more broadly, just looking at overall the Fontan proteome. This is not something that's been previously documented. This paper was fairly recently published by our group in Cincinnati, looking at sort of the overall map of what you see as far as the proteomics of patients with Fontan circulation, and it is wildly different than people with normal hearts. So we really need to understand sort of our baseline group and their proteomics before we can start to sort of separate into high and low exposures and see what is changing. So we've taken that first step, started to understand our baseline Fontan proteomic map and sort of what's going on under the hood, and then we can start to separate out some of these things like environmental factors. And the thing that I am thinking of most acutely are patients sort of on the West Coast in Los Angeles that might have a wildfire exposure, and getting data from that group down in Los Angeles, I think will be really something that, or places in other parts of the world with higher exposure data. Will be sort of a good way to sort of find the signal amongst the noise. So that's the long-term plan. So that's sort of a nice taste of the things that I've been doing and working on and working towards. If anybody has any questions, happy to answer any.